All right, good morning, everyone. Here for the Neuropathology Conference in January 8th, first one of the year. We have a few good cases today, so hopefully get some good case review going today. The first case, I see resident-wise, we have Long on. Long, are you available?
Hey, Sumit, yeah, I'm here.
Perfect. Okay, Long, why don't we get us started with this case right here? You can go ahead and just read it really quickly. This is a very small case summary. We'll go through the details in a second.
Yeah, it's a 50-year-old male, no significant pathological history, presenting with back pain, center to the right, and then pain going down the back of his right leg.
And so that symptom onset gradual, it worsened with activity and when he was lying supine. The majority of it is back pain, and that right leg pain does radiate posteriorly and into the shin. And he initially had sought conservative therapy through his primary care prior to getting any imaging and failed all of that. And only progressively worsened, and therefore he got imaging and then was sent to you. But this is his past medical history, his past surgical. And you can see the real only thing that's of significance to his physical examination is the diminished patellar reflexes. When he was in clinic, he was full strength and full sensation. So is there anything that you want to order for this gentleman?
Yeah, I'd probably start off with an MRI L spine.
Mhm. So I'll give you a CT first.
Okay.
It's just he had a CT of the L spine and an MRI of the L spine. So we'll start with the CT. What do you see here? And this is the L5 body. I didn't label it on the axial, but go ahead and tell me what you see.
Yeah, so there's a lytic lesion in the L5 vertebral body extending through the right L5 pedicle and into the right L5 lamina. Looks like also paraspinal soft tissue.
Very good.
I'd probably want to follow up with an MRI with without contrast.
Very good. And then this is you can see on the sagittal as well, that soft tissue signature does follow into that right L5, L1 foramen as well. It could also explain some of that radicular symptom that he's been experiencing as well. And like you mentioned, that almost exophytic appearance of a soft tissue lesion in the paraspinal musculature. This is that MRI. These are T2 weighted images.
Yeah, so T2 axial sagittal, it's T2 hyperintense lesion. Looks like multilobulated. Again, similar findings of invading the right portion of the L5 vertebral body and extending posteriorly. Is there a contrast enhanced sequence?
There is indeed.
Okay. So with the contrast enhanced portion, again, similar osseous involvement, but also there's significant involvement of paraspinal soft tissue as well. So I guess differential would include metastatic tumors to the bone, lytic lesions. You said he's around 50, 60 years old?
He's 50.
Yeah. So, highest amount differential would be metastatic tumors to the bone. Lytic lesions would include lung cancer, less likely prostate, since that's usually blastic. Could also, I think, be thyroid and I think colon cancer. Also sometimes mets to the bone and is lytic. Other differentials will include primary tumors of the bone, like maybe osteosarcoma or osteoblastoma. But I think those would be less likely.
Very good. Yeah, and we're definitely there's a very very extensive differential. Good job. The question then is obviously then you were insinuating likely metastatic disease. So next steps would also include like a metastatic workup as well. But part of the question, particularly next step wise, this is a lesion that seems to come to this almost to the surface, and so I know one of the things you can always consider is having actually a biopsy done of this specific lesion itself, even before you consider your surgical intervention to help guide how maximally aggressive or how minimally aggressive you're going to be on a case like this. And so that was actually what was done. I'm not going to, for the sake of discussion, I'm going to hold that pathology result. But what's interesting is that pathology result was not the final pathology result that we had obtained after surgical intervention. But you were very, very extensive, very good. We have different. Essentially, you went through the whole gamut of metastases. There is this acronym called FOG machines. I found this on just looking online for these lucent type of tumors of the bone. And so, again, you guys from the board studying time, and me too as well. We're going to be looking at all these different differentials. Fibrous dysplasia, there's a possibility. Osteoblastoma / osteoid osteoma. This is just a differential between the size, so these are essentially the same histologically. Giant cell tumors, METs or myeloma. Something to always keep in mind, particularly with this kind of appearance, this bubbly appearance of sorts, is to consider aneurysmal bone cysts as well. They can be very, very very hypervascular, and so that's something you need to be aware of. Chondroblastomas, hyperparathyroidism, infection as the eye, non-ossifying fibromas, enchondromas, and then just simple bone cysts. And so what is, the operative plan is obviously one of very good discussion. So what do you think should be done? Should we operate? Should we not operate? Obviously, as presenting this, the pathology was one where we decided that it was necessary to operate, but also he was symptomatic, right? He was worsening in his symptomology. So decompressing that L5 nerve root is probably critical for him in his quality of life. What would you do?
Yeah, I think, he's, aside from his, pain symptoms, he's neurologically intact, and on the imaging, it doesn't really show significant invasion of the canal or epidural extension. So I think for him, I'd probably favor a fine, like a needle biopsy, sent for pathology, and then management with radiotherapy, and then a conservative management for his pain.
Sure, I know, and certainly a reasonable option for something like this. We tend to be very, very, a little bit more aggressive than that. He already got the needle biopsy as part of his preoperative workup globally. So we had actually ended up deciding to go ahead and just remove this guy completely. And so the important thing about this case to highlight is also the importance of that preoperative angiogram and embolization. Because you expect, particularly if this is going to be something like a hypervascular lesion, let's say that's the case, then entering into this space to try to remove or try to decompress the thecal sac nerve root exiting is going to be very, very painful, very bloody. And so if you can try to do a preoperative angiogram and embolization for this, and that's what was done, they were able to embolize the L5 radicular artery on the right. And on top of that, in order to get essentially this whole thing out as possible, the plan was to actually do a corpectomy through the front, place an expandable cage, and then also an L5 transpedicular decompression and instrumented. So that was the operative plan. Though the decision to be more aggressive, less aggressive, obviously, it's always up for discussion. This was the post-operative imaging. So very, very nice decompression. You can see the corpectomy cage, essentially that right side with a transpedicular decompression. You can see, obviously, the pedicle there is completely gone. Screws, great alignment. So this was the final result after that intervention. And the most recent MRI suggests that there was no recurrent lesion. Everything was taken. The guy's intact, doing very well. So in terms of pathology, this is Dr. Argultekin. If you wouldn't mind jumping in.
So, Sumedh, I'm going to present the first surgery pathology results.
Mm-hmm.
I think there was some kind of miscommunication between me and my coordinators. I'm not aware of the second biopsy, so you should probably tell after I talk about this what the second specimen showed if you
Of course.
diagnosis, because I wasn't made aware of the second surgery. So anyway, let's see. Can you move? Yeah. So the first surgery after which Dr. Levy, reached out to us and said that this pathology didn't make sense was this one. So what it showed was there was a lot of hyaline cartilage, fragments of bone, and several areas where there seemed to be some reactive new bone formation, but not like a neoplastic bone formation. And some of these you can see on the right top where there is some hemosiderin deposits on the left, and at the bottom you see again more bone, regular bone. On the left lower corner you see once again a lot of reactive bone formation. I'm sorry, reactive changes, including some mononuclear cells, hemosiderin deposits. Next slide. Hemorrhage. Again, hemosiderin deposits on the right side. So bone marrow, and on the left lower, interestingly, some very thick walled blood vessels. And I wasn't sure if these thick walled blood vessels represented, some kind of vascular pathology, or was it part of the tissue that was taken out. That I wasn't sure, but Dr. Elizabeth Montgomery looked at this case and she signed it out as, do we have another slide?
We do. We have one more. Yeah.
Yeah, can I see that? Yeah, so here on the left upper picture, you can see this lace-like new bone formation. Now, when pathologists see this, they say, oh, maybe there is an osteosarcoma, but the differential includes like a healing fracture, a fracture callus. In this case, we didn't see any atypical mitoses, infiltration of atypical cells. Most certainly no carcinoma in this specimen. I looked at it twice. Elizabeth looked at it. She signed it out. It would be difficult to miss a carcinoma if it was here, like a metastasis.
Mhm.
Okay, so once carcinoma is out, then you start thinking, is there a primary bone or soft tissue lesion? Like, giant cell tumor of the bone, osteosarcoma, chondrosarcoma, all sorts of other things. And they didn't make sense either with this morphology. As you can see, irregular areas of bone formation, blood, these streaks of bone associated with cartilage, again, spicules of bone, osteoblastic activity on one side, osteoclastic activity on the other side, as seen in the right upper picture. It just didn't make sense in terms of metastasis or primary bone and soft tissue tumor, this particular specimen. That's why I think she concluded that this was reactive bone formation and not neoplastic, probably a fracture callus. I wasn't sure if she was aware of the radiology at that point.
Mhm.
Anyhow, so that's what the first surgery showed. You said that was a second attempt.
All right. So yeah. So the to clarify, the gentleman only had one surgery, but
Okay.
what was done before was that he was sent to a interventionist who then did a needle biopsy of the lesion before we operated. So what's interesting is that that needle biopsy indicated osteoblastoma when they did it as in the outside.
Oh, okay. I have no idea that was the case, but we don't have evidence of osteoblastoma here.
Which is, I think,
So,
yeah, part of the reason to discuss this case, both from obviously an educational perspective, but just a second review as well of the case. It was just very interesting. The pathology didn't ultimately make sense, which is why Dr. Levy also wanted to present it as well.
Now I see why, because of the radiology. I mean, the radiology shows a lytic lesion that extends into the soft tissue. That doesn't make sense if you just say this is just a fracture callus. It just doesn't explain that.
I mean,
So,
it's definitely not a fracture. It's definitely a tumor. Like Sumedh said, there are two pieces of tissue, one from the biopsy and then one from the surgery. I mean, radiographically and angiographically, it looks like a aneurysmal bone cyst, and I think one of them came back as that, and then it could be osteoblastoma, just because there's so much reactive tissue around it. But it's definitely not a fracture.
okay, yeah, absolutely. I understand that. Looking at the radiology, it makes much more sense what you said. Now, so we have to, in this case, get that other biopsy that was done outside. I don't know if it was read here. The interventional radiologists
Yeah,
need a
it
biopsy.
was here. It was here.
It was here.
Yeah.
Okay. I will reach out to today. This week was a week for us for pathology conference, so a lot of people were out. I will reach to Dr. Montgomery and Rosenberg and have them review the whole thing again, and try to make sense of what the tissues are. This is beyond the realm of neuropathology, as you can see. But the big specimen really doesn't show much in terms of neoplastic tissue. The good news is that this is not a metastasis, so or abscess or anything like that. Okay, so that's the first case pathology.
And so this is what the pathology had indicated. The prior biopsy, again, we'll go through review. The prior biopsy suggests osteoblastoma, despite it having more aneurysmal bone cyst features intraoperatively. So because we're in the kind of boards era, I thought that these are direct SANS questions that have some relationship to whatever topic that we're discussing. So let's see, Vaidya.
Yep, I'm here.
Perfect. So this is a question that you got on your boards. Go for it.
Okay. Let's see here.
So an 11-year-old boy, history of progressing left paramedian thoracic back pain, radionuclide bone scan and bone CT show lesion as below, which is the most likely diagnosis. So this is testing your understanding of, well, what is the pathology or what is the imaging showing you? Why do we use radionuclide scans? And which of these is most common in children?
Sure. On the imaging here, you can see like a well circumscribed lesion right there in the vertebral body.
Mm-hmm.
On the radionuclide bone scan, you have enhanced uptake, which is consistent with like malignancy usually, which is why we do those. You're looking to see where the radionuclides have increased uptake, which indicates increased cell division, like overall increased cell activity, which indicates a malignancy. Given his age, I would say it's probably an osteoblastoma, if not osteoid osteoma.
So to clarify, right, the likelihood of this child having a significant, sarcomatous-like condition is probably pretty low. Its size is going to differentiate between osteoblastoma and osteoid osteoma. And so those histologically will be similar. So do you know what the size cutoff is for those two?
No, I don't.
Okay, so it's 2 centimeters. So if it's greater than 2 centimeters, then just kind of, take my word for it, it's less than 2 centimeters. And so
Okay.
on the actual, the SANS question set, this was an osteoid osteoma. Do you know how osteoid osteomas can be treated medically, like how you can do symptom management?
Yeah, I think osteoid osteomas do respond to just painkillers, the pain from it.
Which one
Osteoblastomas do
specifically?
not.
Which painkiller specifically, or
Like-
oral medication?
Yeah, they typically respond to like oral NSAIDs even.
Perfect. Good. So salicylic acid, like aspirin and NSAIDs. Very good. And these are also another way that this can be presented, or a vignette can be nocturnal pain as well. So 11-year-old boy has a lot of nocturnal pain, and what would, this is the imaging, what would be the next line of therapy? You could say aspirin and NSAIDs. Very good. Next case, why don't we go to Ahmad? Are you on?
Yeah, I'm here.
Perfect. So Ahmad, go for it. Can you read the case vignette? And
Sure. 18-year-old female with a history of migraines presenting with increasing headaches and vomiting.
so this headache is described as frontal and pressure-like, worse when lying down, and slightly improves when with rest when it flares. Vomiting, also self-limited in the emergency room, and it was also associated with transient blurred vision. These are the symptoms, the most nothing past medical, nothing surgical, and otherwise intact besides some mild finger to nose dysmetria. So what do you, just based off this clinical vignette, young girl, lots of headaches, pressure-like, worse when lying down, what is this describing?
Yeah, I mean, it sounds like there's an element of position to it. So like, it's positional headache, probably related from like increased ICPs. The mild finger to nose dysmetria makes me think something in the posterior fossa, maybe compressing the cerebellum, or something that's in the posterior fossa, maybe compression of the fourth ventricle and causing some elevated ICPs.
Exactly. Excellent. Very good. So you get this call because they say essentially you're on call. Jackson West does a CT scan and immediately sends you this.
Yeah. Okay.
So exactly, right on the money. Which side would be more dysmetric, right or left?
Should be right,
Perfect.
like it's lateral. Yeah.
And you can see, right, so you can, obviously, we'll just go through this part quickly. You can see a very hypodense lesion in the posterior fossa with some hyperdensity associated. It's also causing compression of the fourth ventricle here, and then associated hydrocephalus because you can see the temporal tips there. So it all makes sense. What's the next step?
MRI with and without.
So then looking at this, what are you thinking?
Yeah, I mean, so contrast to MRI that shows like I guess like a peripherally enhancing cystic lesion. It has a pretty kind of well-defined border. Yeah, I mean, I'm thinking so maybe like either an abscess, maybe even like a ependymoma, maybe maybe even like a hemangioma.
There's
Yeah.
one childhood lesion of the posterior fossa. So right, she said ependymoma, it's good. Usually midline coming from the essentially fourth ventricle, right? So more midline. Medullose can be in the posterior fossa, obviously, but again, more midline. There are some that can vary, depending on which group it arises from. That being said, most commonly we'd see, middle, kind of the midline medullose. What's one thing that this is likely to be more than others?
Not thinking it's like a.
It has the word juvenile in it.
Yeah, maybe like a pilocytic astrocytoma.
Perfect. Exactly.
So, yeah.
So, based off of this, if this patient was like 60 in a posterior fossa lesion, you're thinking met and then met and then met, right?
Yeah.
But then obviously you have these, younger woman. So JPA, hemangioblastoma, possibly a met, but unlikely given her age. Consider the atypical presentations of things like ependymomas, medulloblastomas, etc. And like you mentioned, abscess is a good one. She didn't clinically look ill, so it's likely lower in your differential, and she was otherwise labs were, etc. Perfect. Operative plan for her. So obviously this needs intervention. Well, even before that, so she's having concerning symptoms of elevated ICPs, but she's neurologically intact when you see her, right? Is this someone that you would just like park in the ICU, EVD ready at the bedside? All her symptoms essentially have resolved. I think we'd all agree that she needs hospitalization to address this, but where would you put her?
I think I would still put her in the ICU.
Yeah. And so,
Yeah,
not
or
again,
just
not
put
an
her on a super
unreasonable
hydro
option.
watch. Yeah.
She was very clinically stable and her family was with her. So I opted to, obviously admitting her and having her totally worked up prior to intervening. But exactly, if you have just globally your clinical inkling when you're in the hospital in the middle of the night, do what you think is perfect for this person, do what you think is right for this person, no matter what, right? So if you think ICU is the move, then ICU is the move, right? Don't second guess that. Anyways, what do you think we're gonna do for her?
I mean, like a suboccipital creamy paramedian. Yeah, okay.
And so, Dr. Gultekin.
Yeah. So I must say that the radiology is classic for juvenile pilocytic astrocytoma with a cyst with mural nodule, no edema around it. I didn't think there was any good relationship with the ventricle and the age group, lack of VHL. All these things point to JPA. PXA would be a distant second diagnosis based on radiology. So this is relatively easy case actually from the get-go. What the pathology shows is to support that idea. It's a variably cellular lesion. On the left upper, you can see the left side has denser, right side has looser areas. So that's one typical appearance for JPA. On the pictures that follow on the right side upper, again, you start to notice the fibrillarity of the cells. On the bottom left, again, these elongated exactly cell processes of pyloid cells. A pilocytic astrocytoma cell is a bipolar cell that is unusual for an astrocyte. Typically, they have multiple processes, but interesting, this looks like a cell culture of bipolar astrocytes with a small nucleus most of the time. And again, two processes. On the right lower, you see hyalinized blood vessel walls, which are signs of a low-grade tumor. And these red areas, that red elongated carrot-like areas in the middle bottom area, those are Rosenthal fibers. Again, those are known to be associated with a pilocytic astrocytoma, but not pathognomonic because they can occur in other situations where around slow-growing lesions in the nervous system. This is within the tumor. Reactive Rosenthal fibers occur around the tumor, such as a craniopharyngioma. Okay, so Rosenthal fibers are present within the tumor. There's pyloid morphology. There's alternating dense and loose areas, hyalinized blood vessels. Next. Of course, no mitotic figures. On the left upper here, you see evidence of previous hemorrhage. So there are some micro hemorrhages sometimes that happen. They may be asymptomatic within the tumor. I have seen 2 cases of pilocytic astrocytoma in a child presenting with hematoma to the ER. So that can happen. Pilocytics can clinically be bleeding tumors rarely, in my experience. And the rest shows the same. No mitosis, no necrosis. Sometimes some vascular changes can be seen, but not like a glioblastoma type vascular morphology. To make a long story short, this is a low-grade glial lesion with features of pilocytic astrocytoma. I don't have the immunos here because of some glitch, but what this is going to be GFAP positive, OLIC2 positive, so glial differentiation markers will be positive. A percentage of these cases will have BRAF alterations, especially BRAF fusion. So, and this may be important in the future if it happens to recur, you have at least possibilities of targeted therapy. Okay, that's it for pathology part.
So, again, in the spirit of board's review, Tyler, are you on? You answer this question for us. Not, maybe, let's see. David, are you available?
Yeah.
Perfect. For it.
All right. So future polycyclic stroma associated with poor outcome. Say A, increased mitosis.
It is a off. So that's a good thing you said that, right? Because this is exactly what they would try to trick you on. So it turns out that increased mitoses still does not portend a poor clinical outcome when you look at these long term. When you have increased mitoses for other tumors, then the likelihood is that that will increase its poor prognostic outcome. What is interesting, though, is that the outcome is most associated with how much of the tumor you can remove. So if you can get a partial resection or a subtotal resection, or if you get a partial or subtotal resection, the outcomes are apparently worse in those cases based off of, I guess, long-term studies where, the single surgeon case series, et cetera. And so when you actually look, this is a direct question from the SANS question bank. The actual answer is based off of how much you can resect, not necessarily these things like endothelial proliferation or increased mitosis, which would normally portend worse prognosis and a more aggressive tumor. Even if you have these in JPAs, it's still considered a World Health Organization grade 1. So it's actually then based off of that, it actually beats location, because you cannot get an entire gross total resection, or it's very difficult to get a gross total resection from the optochiasmatic location. Presence of BRAF mutations do not portend poor prognosis. In fact, as Dr. Gultekin mentioned, a lot of these BRAF mutations, particularly the fusion mutations, are the ones that are able to be targeted utilizing BRAF inhibitors. You also, endothelial proliferation, increased mitoses, again, are more of those red herring answers, but those are not going to be associated with a poor clinical outcome. And finally, Rosenthal fibers don't necessarily indicate poor outcome. There are other diseases that have Rosenthal fibers. Dr. Gultekin had mentioned craniopharyngioma, so that's something to be aware of. There are also some leukodystrophies that can do it. And so, for example, if this was a really young child who basically had degenerative symptoms, no posterior fossa mass, to give you a pathology, and then there's a bunch of Rosenthal fibers, you can also consider like a leukodystrophy. Alexander's disease does this as well. So those are the Rosenthal fibers, pilocytic, craniopharyngioma, and then a leukodystrophy, Alexander disease. And this is I also need a paper for this one. I read the paper on this one. So I also similarly, increased mitoses seemed more of the correct answer, but optochiasmatic location, just because you cannot resect the whole thing. And again, a supratentorial location of JPA is considered worse than an infratentorial location for JPA.
Especially if it's in the hypothalamus.
Yes, absolutely.
Sumed,
yes.
This is Raghib. I'm sorry to interrupt, but I think you make an important point about location. But I want to make sure everybody understands that the optic pathway JPAs in children are a unique entity, which are very indolent, do not require resection, and have a very good prognosis. and that a great deal of harm is created by aggressive surgical resection.
Right.
And that's been an evolution in their management. So I appreciate the A through E options, but I would pick the thalamus or the brainstem as your herring for location, not optic pathway. The distinction is extremely important. They're most common in NF patients, right? And they do not do better with resection.
Mhm. All right, we'll go to the next one. Nadia, I will pick on you again. Or unless Tyler, is Tyler available?
I'm here.
Oh, perfect. Okay, Tyler, go for it.
I texted to Matt. I was like, sure. 34-year-old male, history of fourth-ventricular cavernoma, known tectal lesion, presenting with worsening diplopia.
Got any more of those entries?
Mm-hmm. Very good.
You guys are not going to remember it.
Oh,
Okay, so it's been Paul with serial imaging. He has an isolated left cranial core palsy.
Honestly, you're not.
Oh, and he had a 26 years earlier.
I did all good because we got advantage.
someone else on. I hear a lot of.
Oh, sorry.
Yeah,
I
I'm
can
trying to
put
find
it
that
to
later.
Matt.
Give me a second.
Hold
I
on.
see.
Here, is this Med? Sorry.
Yeah, perfect. Perfect. Yeah, so exactly. So this gentleman basically has worsening diplopia. He had a tectal lesion being followed with serial imaging, so we know that it's there. And he had a prior fourth ventricular cavernoma. The Dr. Morkos had done a suboccipital craniotomy for 6 years prior. That was also being followed as well. Essentially intact besides a left cranial nerve 4 palsy, which ultimately also has been pronotes worsening as well. So you get imaging and you see this lesion, and it has increased in size from 2020 to 2023. So it is enlarging.
Okay,
What do
yeah,
you
so this is like, yeah, it's a flare. It's an axial flare MRI with looks like eccentric to the right sided tectal like flare hyperintense lesion.
Yeah. And so again, this area right here, tectum, what exactly, like, what would these things be called?
The clicular?
Perfect. And what syndrome is associated with clicular or like clicular compression?
Paranod?
And what are the symptoms of or hallmarks of paranod? Just like the
Yeah, like lid retraction, like upward gaze palsy.
Good. They also have an nystagmus when looking up as well. And they also have pupils that accommodate but do not react to light. But yeah, exactly. The upward gaze palsy is the more is the more clinical relevant finding you just immediately see. You can also, this is a GRE scan suggesting that this is not a hemorrhagic lesion either, so likelihood of being cavernoma is also low. You can see that's outlined right there. So differential diagnoses for tectal lesions.
Sure. So tectal lesions, could include like a tetraglioma. He's 33, so I guess that could be on the list. Metastasis. I don't know if this was contrast enhancing since just the flare signal. Could be like I suppose it's near the like pineal gland region, so I guess you could consider potentially some of the like the germ cell tumors, but I mean it's kind of posterior to that. I guess I would probably put like tetraglioma or something like that higher on the list, especially given like prior history of training.
Gotcha. Yep. So essentially, tectal glioma astrocytoma is the most likely thing it's going to be, right? Its location, it is not contrast enhancing. So I didn't give you that image, but it is not enhancing. You can, this is just to complete the entire differential. You can consider any of these pineal related tumors in that region, but we know it's not. It's clearly coming from the tectum. Cav-mal, possible. This guy has a history of cav-mals in the past, but again, GRE was negative. Next, the guy is young. You can also consider hamartomas, especially the patients have NF1. But again, this is likely a tectal glioma astrocytoma. And so part of the surgical decision making for this would be based off of its progressive symptoms, we can assume that we can attribute a worsening diplopia to some sort of superior colliculi dysfunction. Operative plan would ultimately be what, essentially biopsy this guy. You can't really necessarily completely resect this thing. That being said, it is growing, so you want to be able to at least guide target therapy. What's interesting about this, cool about this case, was that the approach taken supracerebellar infratentorial for an open biopsy. I'm kind of going a little bit faster because we have one more case after this too. So the biopsy was done, and these are the path results.
Oh, very, very small tissues, understandably, because it's a tactile lesion. It shows lesional tissue to start with. That's a good start. And we determined that it looks more like a primary neuroepithelial tumor, meaning like a glioma or a ganglion cell tumor, you know, in that category. The third layer is doing some immunohistochemistry, looking at the morphology carefully. And what morphology shows is myxoid background, as you can best see in the left lower picture. And there are some nests of cells, innocuous looking, benign looking, round tumor cells, occasionally, actually more than occasionally, making these especially perivascular rosette-like structures, not necessarily in an ependymoma-like, but especially, again, left lower picture shows these cells forming structures. So rosette-like structures. And on the upper right picture, there's a big neuron-like cell at the mid-top. Myxoid background, rosette-like structuring, round small cells, no mitotic figures, no attributes of malignant behavior, necrosis, vascular proliferation, mitosis, etc. And we were very careful for not doing too much immunohistochemistry here, because we thought that we had a diagnosis, but we need to send NGS. So it's GFAP positive. Do we have another slide?
We do, yes.
Okay, here you can see with OLIG2 on the left upper picture and right upper picture, the distinct rosette-ish structures. See those round little rings of cellularity? That's very typical, and these would be synaptophysin positive if we did it. We didn't do it deliberately, but so make a long story short, after obtaining the Ki-67 index very low, like less than 1%, and with these morphological features, we thought that this is an example of a rosette-forming glioneuronal tumor. Okay, it was described in the fourth ventricle first, and there's an overlap of this morphology with DNET, which typically occurs in the temporal lobe, and also sometimes what we call plenty, pleomorphic neuroepithelial tumor of the young. So these revolve around FGFR mutations, and they are generally grade 1 tumors. So grade 1 tumor, most likely rosette-forming glioneuronal tumor, and needs NGS. I don't think it's back yet, but that's where we are.
Perfect. Yeah, I didn't see any of the NGS results. I looked, but
grade 1 lesion, glioneuronal tumor, not an infiltrative astrocytoma, certainly not a pineal tumor or germinoma or anything like that.
So
that's it.
So, and similar, love these little test questions, right? So something to always keep in mind, right, is not just obviously the location of the lesion, it's rather the lesion itself, but the location. And so a lot of the in this area, right? The aqueduct is right there. And so this, again, a Sands Bank question from the actual, the CNS Bank itself. Let's see, Vaidya, are you on? Still?
Yeah, I'm on.
Perfect. Go ahead and kind of read this question. Essentially, it's asking, this patient has a 5-year-old child vomiting, high head circumference, probably, definitely hydrocephalic from the MR scan, enlargement of the lateral third ventricles, and a midline lesion consistent with a tectal plate glioma. What are you going to do for this gentleman, this child? So.
Yeah, I think I would go with endoscopic third ventriculostomy and a biopsy.
Gotcha. So with a tectal glioma coming endoscopically to get the angle to go back, is that an easy or hard angle to do?
Probably difficult.
Probably difficult. And it's not that it's not possible, but you're going to have to traverse through a lot of eloquent and important tissue to get into the back of the tectal region, right?
Right.
So generally speaking, we would, and this is one of those lesions that you can diagnose essentially with relatively good certainty just with the radiographic signatures. Now, again, if there's any significant changes to the actual lesion or worsening symptoms, then you have to consider other possibilities. But in a child who has a consistent, clear lesion, it's likely okay to do this without biopsy, in the sense that you're probably going to hurt this kid if you try to biopsy this. And again, your surgical goal is not to discover essentially what this is. You already think it's a tectal plate glioma. And again, indolent, very slow growing. The best thing to do for this kid is to treat the hydrocephalus, right? And so then the question is really asking you, do you understand the difference in when an ETV, it would be preferable to a VP shunt? And so this question, so the answer to this question was endoscopic third ventriculostomy without a biopsy, because of this, right? And so this is something, that you should always just, it's a ETV success score, something to help guide a lot of these decision makings that you do. But essentially this child, 5 years old, puts him at 40% success rate just on the age. The etiology of tectal tumor places him at another high possible success score. So he's 70% likely, the percentage of possibility of ETV success is 70%. In our guy, in our 30-some-year-old, it'd be even higher as he's over than 10. So this is, again, something that's just unfortunately rote memorization, but the concept being younger kids more likely to fail. Any sort of etiology that causes additional or, causes the likelihood of you to reclose an ETV hole to be higher. And again, previous shunt versus no shunt. If they've had a shunt prior, then the likelihood of them having an ETV success after they've already had a shunt is probably going to be low. So again, this is just something that you have to kind of understand and unfortunately memorize. But structural pathologies and slow growing pathologies will be high on your ETV success score. Hemorrhage will be low, and then infection will be even lower. So this is one thing, something to study as well, ETV success score. Make sense?
All right. Yep.
All right, last case. We're kind of running short on time, so I'm going to go through this one pretty quickly because this is an interesting case. 46-year-old male fell 10 days prior to presenting and is presenting with low extremity weakness. The guy's otherwise neurologically, without issue. He fell in the shower, no history of cancer, denies bowel bladder incontinence anesthesia, but now as a result has to use a walker even short distances, and he feels that his trunk is less sensitive than the rest of his body. No significant history apart from some surgery in the past. He's hyperreflexive, has a sensory level at the nipple line, and he's pretty weak in the lower extremities. Uppers are completely fine. And so this is a lesion you'd be thinking of where? Let's say long.
Sorry, Sumit. So it looks like weak in the IPs. He's hyperreflexic. And then does he have clonus at all?
He does. He has some beats of clonus and
a sensory level at the nipple line. So yeah, so since he has a sensory level at the nipple line, I would think probably around T4.
Exactly. So around that T4 area, you're concerned that there is some sort of pathological issue at that level, fracture or a mass or something. Your inclination is correct. This is the CT scan that was done prior to transferring him over to you. So you can see though this is C7, T1, what used to be T2, T3. So you can, so with that information, right, you can describe it again. I'm blowing through this pretty quickly, right? You have a pathological fracture, complete loss of height here. You have some lytic lesion that's causing, obviously the bone to be weakened at that level. There's some component of epidural tumor, and you can see this is the MRI that was done. Very significant retropulsion of both bony elements as well as cancer tumor, rather tumor. We don't know what it is quite yet. It involves a pedicle. There's epidural enhancement. This would be what's called an epidural spinal cord compression score of 3, circumferential, causing significant compression. That's like the Bilski score. You can look that up on your own. Again, contrast enhancement, spinal cord is basically being squashed. This guy needs surgery. So differential lung.
Yeah, so again, differential would probably be metastatic metastatic disease. So like lung, thyroid, kidney, melanoma. Yep. I would say less likely primary bone tumor.
Yeah, exactly. There's metastatic disease, right? This is likely going to be a maybe multiple myeloma. Like you mentioned, the other kind of the bone specific ones. Operative plan for this gentleman.
So I think it needs a emergent decompression. So I guess you said it was at T3 is where the T3 is where the
T2, yeah,
T2. So I think probably bilateral transpedicular decompressions at T2. And then probably fuse one level above and one level below.
I would even extend it slightly higher. You're at essentially a transition level with the low cervical, high thoracic lesion. Plus, you are going to be taking, the pedicle in this like a mobile area of the spine. So we actually opted to go a little bit higher. So we went C6 to T5. Also, there is something. One of the images indicated that maybe the right T3 pedicle was slightly involved as well, based on the imaging. So this is something, again, plus or minus levels. Again, just make sure that the construct is solid and you've done a solid decompression on the guy. We thought we could just get everything from the right, so that's what we opted to do. 2 classifications. Again, we're going to go quickly through this part. 2 classifications used to guide operative decision making. The SINS classification. Again, this is just something to understand conceptually. This will essentially help guide the surgical intervention and stabilization of pathological spine fractures or any of these like tumor related issues of the spine based off its location, right? If you have a junctional area, the likelihood of instability is higher. Pain with movement implies some level of axial instability, so that's going to increase your score. If the lesion weakens the bone, that's going to increase your score. If there is significant radiographic misalignment, it's going to increase your score. Vertebral collapse is going to increase your score. And finally, posterior lateral involvement, i.e. the posterior tension bands, that's going to increase your score. So this guy basically has, it's obvious based on the imaging, but this is just another way to classify it mentally for those with, the borderline cases. There's also the NOMS criteria, neurologic, oncologic, mechanical, systemic, to help guide what you're going to do in terms of decompression, radiation, stabilization. So this guy clearly is not only neurologically compromised, we don't know oncologically what it is. He's able to tolerate surgery, but he's mechanically unstable, so you need to stabilize him first. So this was the pathology. Very interesting.
Yeah, very interesting case. It was looked at by Dr. Yantis from the GI division. Very strange morphology. We have a bunch of glands that are kind of conforming to each other in this very dense glandular environment. They stain with keratin, and sometimes they form these solid areas on the right lower picture. This looks like I mean, the glands themselves, they don't look high grade. And that sometimes happens in carcinomas. The question is, where is this coming from? It wasn't very clear to the pathologist at that time to define a primary, likely primary focus for this particular lesion. It looks like a carcinoma, adenocarcinoma to begin with, to be more specific. And it kind of looks out of nowhere, adenocarcinoma. The patient does not have, as far as I know, a primary focus anywhere, right?
Correct. He completely negative.
Yeah, it looks, and my thoughts were like sometimes midline tumors can be germ cell tumors, and in the germ cell tumor, you can have a carcinoma that sort of overrides and overwhelms everything else. And then you have a carcinoma, but you don't have the teratoma background. You scratch your head, you wonder where it's coming from. That's one of the scenarios. So, you know, like a monodermal teratoma or a carcinoma arising in a teratoma scenario. That does happen. This thought was not entertained in the pathology report, but I think it was signed out as an adenocarcinoma, and then a big, huge paragraph essentially telling that we don't know where this is coming from. So it is an epithelial tumor. It's a carcinoma, but the origin is unknown.
I looked at this, the pathology report has suggested a Caris, like CARIS, Caris molecular profiling. So when the actual Caris profiling came back, it was apparently, according to the oncology clinic notes, they're saying it's 90% similar to cholangiocarcinoma. So malignant neoplasm with adenocarcinoma with some elements, similar to a cholangiocarcinoma, even though he had no evidence of anything wrong with his gallbladder, which I think was very interesting.
It is interesting because I'm not surprised to see this. It was cytokeratin 7 positive, which, if you're thinking of a GI tract, lower GI tract doesn't make sense. The best fit would be a cholangio, actually. But it doesn't look that aggressive histologically. It doesn't have a single mitotic figure. It doesn't have any, again, histological attributes of aggressive behavior. Very strange looking. Looks almost like an adenoma in some areas.
Yeah.
So are you guys gonna zap? What happened?
So he's actually already getting radiation therapy now. After
Okay.
surgery, he returned to full strength. So he significantly improved after decompression. So he's going on right now getting chemotherapy radiation for this.
And the biliary tract should be carefully looked at by, I guess, some specialized radiology, just to make sure that there is no cholangiocarcinoma. That can be sometimes difficult to detect, right?
Yeah, absolutely.
Intrahepatic.
Intrahepatic, yeah.
Okay.
All right. Essentially, this is the last question. They're asking what corridor surgically offers the widest area to enter into the anterior thoracic spine, resected thoracic vertebral body tumor, anterior cord compression, etc. Is essentially telling you which of these gets you to the front of the body with as much, front of the ventral area of the thecal sac, the spinal cord as aggressively as possible. Extracavitary approach, and this is the picture. So again, laminectomy gets you the middle, the transpedicular gets you slightly more with the through the pedicle. Costotransversectomy essentially tells you you're taking a little bit of the rib, the transverse process, and the pedicle. And finally, lateral extracavitary approach gets you that whole segment of rib all the way into that anterior portion of the vertebral body. So this is just something you have to memorize. It makes conceptual sense. All right. Well, thank you very much. Sorry, we're a little bit over. Ahmad, I think you're up.
Okay, so I'm gonna be giving a talk on IDH mutant glioma and tumor-derived exosomes and the systemic immunosuppression related to tumor-derived exosomes in IDH mutant gliomas. So a lot of the work for this presentation was actually done between my third and fourth years of medical school when I was working in in a lab with my mentor, Dr. Monclar at the time. Yeah. So IDH mutant gliomas. So it's a term that we've all heard. Kind of relates to underlies the isocitrate dehydrogenase enzyme and mutations pertaining to that enzyme. The most commonly you see IDH1, which is single nucleotide polymorphism, usually at the 132 location, where you have an arginine to histidine change. You also have R172H and then IDH2, which is less common. But in gliomas, you see IDH mutations in almost 80 to 90% of diffuse low-grade gliomas. But you'll also see IDH mutations in other human cancers as well, some GBM, AML, melanoma, chondrosarcoma, and cholangiocarcinoma as well. And although IDH mutant gliomas are correlated with having an increased survival in patients, 9 years versus 18 months compared to wild type, interestingly, the tumor microenvironment of IDH mutant gliomas are immunologically cold, and we'll kind of get into that and dive into what that really means. So on the figure on the right, I show like a kind of a schematic of the IDH mutation, the kind of like downstream products of IDH. So you have isocitrate being reduced to alpha-ketoglutarate, and when you have IDH mutation, you'll reduce alpha-ketoglutarate further into 2-hydroxyglutarate. And it's really this accumulation of 2-hydroxyglutarate that causes a lot of the changes that are attributable to what we see in IDH mutant gliomas. So buildup of 2-hydroxyglutarate starts to inhibit alpha-ketoglutarate dependent deoxygenases when you have a buildup of 2-HG. So that inhibition of alpha-ketoglutarate really leads to a lot of demethylases losing their function. So what happens with that is that you start having extensive genomic methylation and leading to epigenetic remodeling. So a lot of CPG island methylator phenotypes that are associated with glioma are related to the change that you see that are driven by IDH. And what you see when you have suppression of transcriptions of these genes are a lot of downregulation of various immune genes and tumor suppressor genes. Things like chemokines like the CCL2 family, CXCL family. The CCL2 family is known for recruiting leukocytes, monocytes, memory T cells, such and so forth. And the CXCL is chemotactic for peripheral leukocytes as well. You also have some downregulation of interleukins and more or less commonly known proteins such as UL16 binding proteins, which are what we call NKG2D ligands. So basically ligands that natural killer cells respond to in terms of to initiate either tumor cytotoxicity or any kind of cytotoxic responses. On the right is actually a heat map that shows hierarchical clustering dependent on the IDH mutation. So if we're looking at about 1,600 of the most common immune genes, and we look at low-grade glioma, we will see hierarchical clustering kind of separating these two groups out based on IDH status. And then, so it really goes to show you that the differential gene expression within the subset of immune genes really drives kind of like the phenotypic differences that we see in IDH mutant glioma. So what does that really mean in terms of the tumor immune microenvironment when you have widespread suppression and hypermethylation and suppression of some of these immune genes? So the figures on the right are actually flow cytometry data that we had collected in the lab. So if you're looking at red, which is IDH mutant, and blue, which is IDH wild type, if we're looking at flow cytometry studies of CD45 positivity cell, which is a marker for leukocytes, you'll see a significantly decreased amount of tumor infiltrating leukocytes within IDH mutant gliomas. And you'll see exactly the breakdown of different types of cells as well. You'll see a decrease in macrophages, monocytes, polymorphic nucleosides and about and in terms of CD4 and CD8 cells, you don't really see a statistically significant difference, even though numerically there was a decrease in those as well in IDH gliomas. So the question really becomes, what drives the difference in the infiltration of tumor infiltrating lymphocytes in IDH glioma? We know that there's a lot of downregulation in immune genes, but there's a systemic effect also at play that can that leads to decreased chemotaxis that's responsible for the presence of these tumor infiltrating lymphocytes within these tumors. When we do in vitro studies, looking at neutrophil migration, you can actually see decreased neutrophil migration in IDH mutant glioma as well. And so it's important to kind of recognize that there's a absolute number decrease in tumor infiltrating lymphocytes within IDH mutant gliomas, but what's just as important is actually the makeup of the cells that you actually see within tumors themselves. And this slide kind of gets into that a little bit too. So the middle figure here gives you the proportion of the lymphocytes that are either myeloid derived or lymphocyte derived. And when you're looking at the figure in the middle, you actually have to take you have to keep in mind that even while the heights of the bars are the same, it's just to kind of really accentuate the differences in the proportions. But you have to remember that within IDH mutant gliomas, there's an absolute decrease in the number of total CD4 positive cells anyways. So if these were to scale, the bar on the left in the middle figure would actually be a lot smaller. But it goes to show that there's a statistically significant increase in the proportion of myeloid-derived cells within IDH mutant gliomas compared to IDH wild type. And that's important because a lot of these myeloid-derived cells are immunosuppressive. So the figure on the left that shows the two bar graphs will show in IDH mutant gliomas, you have a statistically significant decrease in M1 type macrophages, which are some of the macrophages that are actually responsible for innate immunity. And then you have an increase in M2, which are associated with more of a suppressive kind of phenotype. Same thing, you see increase in the amount of myeloid-derived stem cells. And when you look at the figure on the right, you see a decrease in the proportion of lymphoid-derived cell types. So you actually have a decrease in NK T cells. You actually have a increase in CD4 cells, which are immunosuppressive, and an increase in regulatory T cells, which are also known to be immunosuppressive, and a decrease in CD8 T regs, which are again responsible for some of that immune response, anti-tumor immune response. So this can all be attributable to the epigenetic changes that you see when you have a buildup of 2-HG that drives the genotype in IDH mutant gliomas. So the question also becomes: is there a way to reverse some of the epigenetic changes that you see with IDH mutation? So this is actually one of the things that we also looked at in the lab, where we used a demethylating agent, which was decitabine. And once we treat our stem cell lines with decitabine, you actually see upregulation in some of those same proteins that were previously downregulated in IDH mutant gliomas. More specifically, you see upregulation in UOBP1 and 3, again, with either NKG2D ligands that are responsible for NK cell-mediated tumor cellular cytotoxicity. So treatment with decitabine seems to at least improve the expression of UOBP ligands and increase NK cell-mediated cytotoxicity in our stem cell lines. Not only that, but I mean, this also just kind of shows you like a significantly increase in the again the natural killer cell activity against these tumors, and they peak around 7 days even after washing out decitabine. So what other changes do you see in the tumor microenvironment when you're treating with decitabine? And you kind of see tumor in our in vivo studies and in mouse models, you see decrease in tumor size, which we assume is going to be usually responding to the increase that you see in natural killer cell activity. So we actually have a decrease in the growth of our IDH mutant gliomas, and once we treat with decitabine, kind of reversing those epigenetic factors. But I think the more interesting takeaway from trying to reverse some of the hypermethylation that you see and reverse some of those epigenetic changes is, again, the differences in the cell type within the tumor microenvironment. So we actually see reversal of a lot of the immunosuppressive phenotypes that we saw that are inherent to IDH mutation. So treatment of IDH mutant cell lines with decitabine increases, like we assumed, with the composition of the tumor infiltrating natural killer cells, but also the macrophages, increases dendritic cells, and it brings these back up to almost the IDH wild type levels in both of these cases. So the mechanisms of immune escape in IDH glioma, so we kind of start to stratify them into two different pathways: cell intrinsic and then tumor cell extrinsic. The tumor cell intrinsic escape is what we kind of look at when we see the epigenetic changes that lead to downregulation of some of these ligands and factors like these NKG2D ligands that decrease the amount of natural killer cell activity that you get in anti-tumor response. But there's also this question about, what is the cell escape, what is the mechanism of tumor cell escape that you see in a systemic level when you have more of immunosuppressive leukocytes infiltrating the tumor microenvironment of glioma. So to get an understanding of these systemic effects and how these tumors can kind of communicate with the leukocytes that we have in our peripheral system, we kind of started looking at this idea of exosomes. Basically, what are exosomes? And we'll go over that briefly as well. Basically, small extracellular vesicles that are released by all types of cells, carry a lot of genetic material like nucleic acids, proteins, enzymes, lipids, cytokines, and usually in a lot of tumor-derived exosomes, you see a lot of immunosuppressive proteins. And exosomes have been also shown to cross the blood-brain barrier in multiple studies. So there's a way to mediate some kind of communication between the central nervous system and the peripheries. Obviously, there's also going to be some local effect, also some element of autocrine and paracrine signaling, and kind of helps to mediate intercellular communication. And in a lot of studies, that have looked at the role of exosomes in cancer, they've been shown to really drive tumor progression. Again, I think it's really the biggest way a lot of this happens is kind of just direct transmission of genetic data. We'll call it horizontal information transfer from either tumor cells to tumor cells or via the bloodstream into other sites, and that's how we can kind of see tumor growth in different areas and even metastatic disease into other locations in the context of other types of cancers. So exosomes can also kind of be called or known as oncosomes, just because of the ability to carry tumor genes between tumor and normal cells. Because of cellular proliferation, a lot of tumor cells generate and secrete larger amounts of exosomes compared to normal cells, and that has its own influence on the tumor microenvironment. Also, you'll see a lot of some exosomes can kind of activate the TGF beta pathway, and you'll see the cancer-associated fibrosis kind of affecting the tumor stroma. You can have exosomes also promoting angiogenesis, and then obviously the tumor infiltrating lymphocytes because of cytokine production and things like NKG2D ligand productions, also, or decrease in NKG2D ligands, or decrease in T cell receptor signaling. You can see differences in types of tumor-infiltrating lymphocytes depending on what exosome genetic information is being carried. This is actually from a paper published by Whiteside et al., which shows various different types of cancers and the role exosomes have in those cancers and the effect that they have. So, for example, in AML, the exosomes carrying expression for TGF-beta will affect NK cells to kind of decrease cytotoxicity, and then there's the list kind of goes on in terms of kind of just really highlighting the growing role of growing understanding of the role of exosomes when it comes to cancer progression, just not just in glioma but also outside of glioma. So we looked at exosomes within IDH mutant glioma and kind of mimicked a lot of the findings that's already out in the literature. We saw that our IDH mutant cell lines that we had cultured in the lab, they were producing larger quantities of exosomes. They tended to carry more of the immunosuppressive proteins, and then they were also just carrying overall larger quantity of proteins as well. So the figure on the right, kind of the bottom figure, shows again the concentration of number of proteins and particles, and so how much material the exosomes are physically carrying in IDH mutant compared to IDH wild type, and you can see that the exosomes, even though it looks like they're larger in size compared to IDH wild type, that wasn't really significant, but they're definitely carrying a lot more genetic data and proteins. And when we look at some of the more key players of what kind of proteins are being expressed by some of these IDH mutant exosomes, you see an increased ratio of TGF-beta, you see an increased ratio of CD9, and then CD39, 73. So some of which are also immunosuppressive in nature. This figure is a little hard to see just because I couldn't format it really well for you guys, but this also kind of highlights some of those proteins that we had interest in the lab that are related to natural killer cell activity and other chemokines that are associated with that are usually seem to be downregulated, that lead to immunosuppressive microenvironment in IDH mutant glioma. So what this goes to show is basically that the tumor-derived exosomes from the IDH mutant gliomas kind of mimic what the gene expression is in the parent cell, and kind of suggest that these tumor-derived exosomes that are able to kind of cross into the bloodstream and kind of venture far out from the site of tumor itself may modulate immune cell chemotaxis from the peripheral circulation into the tumor microenvironment. So again, I think to kind of prove that not only that tumor, in at least in our studies, that tumor derived exosomes cross the blood-brain barrier, but also communicate with the periphery. We showed we did injection of radiolabeled tumor derived exosomes into the internal jugular vein of several mice, and kind of graphed the time for exosome uptake into certain different areas of the different organs, and the time it takes for those to be kind of taken up. And you can see that in brain, liver, kidney, and lung, you get a significant amount of rapid uptake of exosomes into those peripheral tissues. So obviously across the blood-brain barrier as well, and about 80% in at least in the brain was taken up. 80% of the exosomes that were administered were taken up, with only about 20% laying in within the capillaries of the mice that we had injected. So definitely there's a bidirectional communication between exosomes and the site of where you have tumor growth that leads to some kind of communication with the periphery in terms of immune regulation and other chemotactic factors. So looking at really the influence of tumor-derived exosomes and the systemic immune characteristics within IDH mutant glioma. So when we treat nude mice with that are with IDH mutant or IDH wild type exosomes, we see a exosome genotype dependent change in the composition of the systemic immune landscape. So basically, IDH wild type mice treated with IDH mutant exosomes showed a reduction in circulating natural killer cells, dendritic cells, and macrophage populations, similar to what we see with off the bat when we're looking at the tumor microenvironment of IDH mutant gliomas. Again, you see an increase in some of those immunosuppressive cell populations, also like the MDSCs. So it's interesting to see that administration of IDH mutant tumor-derived exosomes can restore the peripheral immune landscape associated with IDH mutant tumors, even when the tumor that the mice are harboring are IDH wild type. Interesting, however, that we didn't see the opposite effect where we would take IDH mutant bearing mice and treat them with IDH wild type exosomes, and we didn't really see a difference in the circulating natural killer cells or dendritic cell populations. And that could also be because the inherent genotype it overpowers the genetic alterations that we're trying to introduce by introducing exosomes into the live mice, but it's hard to say exactly what drives what leads to lack of difference in that change in the IDH mutant mice. So exosomes generated by IDH mutant cells again increased circulating monocytes and decreased regulatory T cells in tumor naive mice, and that's what we see in B and F over here, which are statistically significant. So it's kind of just reiterating the data from the point before, but again, and this is done right here in our nude mice again, and kind of looking at this time the systemic the influence of the exosome on the systemic immune characteristics. So again, injecting nude mice with IDH wild type or IDH mutant exosomes, we can see that there's significant changes in the number of monocytes, MDSCs, and also in not significant macrophages in this chart, but yeah, so it kind of reiterates a lot of the changes that we saw that are inherent to IDH mutant glioma. So overall, what we kind of showed with a lot of these studies is IDH mutant gliomas and the immune microenvironment that they have within the tumor microenvironment via exosomes it's able to communicate with the systemic immune state of patients and of at least within in vivo studies within our mice studies as well, which really goes to show that it encourages a globally immunologically cold state. The exosomes have been shown to kind of mediate some of the chemotactic factors across a wide range of immune cells, including those outside the blood-brain barrier. And IDH mutant exosomes kind of reflect the genetic material of the parent cells that they're derived from, and lead or feature kind of like the decreased genes involved in immune cell trafficking, including CCL2. Really goes to show that there's a way for the systemic immune environment to be influenced outside of the local tumor microenvironment when it comes to IDH mutant glioma. And the idea is, whether that kind of sets up possibilities for therapy where you either by viral therapy or where you can kind of introduce some of these ligands such as UOBP1 into the systemic system to kind of have an upregulated response and natural killer immunity within tumors and such and so forth. But yeah, I think that's the end of my talk. Yeah. If anyone has any questions, I can try and answer anything too.
Great talk,
Okay.
Ahmad. That was, some really good work, and hope we can continue some of that work.